everyone. Since we didn't get a chance to go over the pain lecture, and we're probably not going to get a chance to talk about it in class because of the poster session and the guest lecture on Thursday of this week, I'm going to just go ahead and record a few of the pain slides of what we were going to talk about in class. And so I'm going to be trying this product called Camtasia, and we'll see how this works out. Okay, so we ended off last class talking about chronic illness, and pain is obviously a symptom of chronic illness, but also a type of chronic illness. People who have chronic pain are considered to also be suffering from a chronic illness in some sense. Of course, that pain may be coming from some other illness. Now, as far as what we're talking about when we talk about pain, pain by definition is some kind of unpleasant sensory experience that someone is going through. And the really critical part of it is that it is subjective. And so people experience pain in different levels. Similar stimuli might feel very different to different people. They might report it as being differentially painful. It's also multidimensional. I'll show you some examples of pain scales in just a few minutes. But pain is not just, are you in pain from 0 to 100, but pain can also be aching or throbbing. It can be recurring. And so there are different things that we consider when we're trying to measure pain. Now, of course, the most important thing that we're talking about when we're talking about pain is the difference between acute pain and chronic pain, because acute pain is somewhat adaptive. It's usually telling us that there's something going wrong, like we broke a leg or cut ourselves. Chronic pain, on the other hand, can often be very maladaptive, and often we don't really know how to fix it very well. So here's some pretty gross pictures that show you some examples of things that cause acute pain. The characteristics of acute pain are that it's, by definition temporary, it is acute, and it usually has a pretty specific trigger that we can recognize, like, in these images, a cut, a wound, and often with acute pain, this is something that can heal, and so our body can resolve this on its own or with help from various medications and stitches and things like this. Now again, we consider acute pain to be fairly adaptive because it's basically signaling to us that there's some danger, that we've hurt ourselves, and we're trying to learn from that. And, in the wild, when we think about sort of how we talked about stress being evolutionarily adaptive, pain is the same thing. You want to learn that you shouldn't touch a hot stove because it hurts when you do it, or you want to learn that you shouldn't walk barefoot on glass because that hurts you. And so these are definitely things that are important for human survival. Now, as far as distinguishing between acute pain ends and when chronic pain starts, we usually set a cutoff of about 6 months, and pain that lasts less than 6 months is usually considered to be acute. Now, chronic pain, on the other hand, can start in an acute manner, but then it lasts for these longer periods of times, over 6 months. It can be related to the same things that that are related to acute pain, like tissue damage, but it also may have no known origin, which is really what makes chronic pain more complicated. With certain illnesses like fibromyalgia, people have these painful symptoms, but we really don't necessarily know where they're coming from. And when we consider adaptive significance, it's typically not thought to be adaptive because avoiding activity isn't necessarily going to include it. You just have this chronic pain. So think about back pain. If your back is just hurting all the time, not doing anything doesn't necessarily make that go away. And so it's not in the same way adaptive where it's telling you not to touch a hot stove or not walk on something. It's really just giving you this chronic underlying pain that hurts you without really helping to resolve or teach you anything. Now, as far as the different kinds of chronic pain, we usually divide it into 3 kinds: benign, recurrent, and progressive. Benign is typically defined by being unresponsive to treatment. Lower back pain is often what we talk about in this environment. Recurrent pain, on the other hand, is typically something that is more intermittent. And so when you think about people who suffer from migraines, people can start having migraines in their teenage years, maybe like once in a while, once a month, once a week even, or even go years without having a migraine and only to have it come back again. Now again, recurrent acute pain, even though it is this shorter lasting pain, a migraine does usually only last for maybe a day or even a few hours, but because it's happening over and over again over a period of years, it is considered to be chronic. Now, finally, progressive is a type of chronic pain that tends to get worse with time. There are many degenerative diseases like rheumatoid arthritis, cancer, where our bodies are getting sort of worse and worse. And with these, unfortunately, the disease does result in more and more pain. Now, as far as the causes and consequences of chronic pain, we don't often necessarily know what's causing the physical pain itself. So with cancer, for example, you might have pain in parts of your body where you don't necessarily have a tumor. Arthritis, we do know that, people who have arthritis in their hands, for example, their hands hurt. That makes it fairly obvious. But there are other things like psychogenic pain, which is really considered to be the sort of pain that's in your head. And we really don't know the physical cause. We don't know why the person has it. And so psychogenic is sort of the all other kinds of pain excuse. And I should correct myself. I mean, with cancer, there are certain treatments that do result in pain. So in some senses, we do really know the causes of that physical pain. Now, the other thing that might actually cause people to have chronic pain is, of course, psychology. So we talk about pain a lot in the psychology field because pain is highly intertwined with how we feel. And so people talk about pain-prone personalities, and what's going on here is that it's not the case that pain is typically thought to be entirely caused by one specific kind of personality, but personality types can definitely change how we perceive pain, how we report pain, and so forth. And so the ones that are most often studied are things like neuroticism. We talked about neuroticism when we talked about personality in general, and this is really the kind of personality type which is very negative. People who are neurotic are often very anxious. They're very high in depression often. But more importantly, they very much interpret mild bodily symptoms as being more severe than the person who is low in neuroticism. So obviously someone who is high in neuroticism would report more pain because that's sort of the definition of that personality trait. Now, surprisingly, there's other personality traits that might not as obviously be related to pain. So, for example, the extroversion to introversion scale that we also talked about when we talked about personality, people who are low in extroversion or who are introverts also tend to report more pain, and people who are passive copers. So we talked about coping style, and people who tend to not do anything about the stressors that they're facing, they tend to avoid them or maybe just deal with them in very sort of withdrawing ways where they're not actively dealing with what's going on. Those people also tend to experience more chronic pain. As far as the consequences of chronic pain, it's obviously very distressing. I mean, when we're in constant pain, it does interfere with your life. It can make you feel very depressed. Some people get very angry. They get very anxious. And of course, that is actually going to be somewhat of a feedback loop, because when we are in a lot of pain and we get sort of negative because of it, the negative emotion actually is known to relate to higher levels of pain because it sort of focuses your attention on that painful stimuli or that painful experience. And so being negative actually makes you pay even more attention to your pain and then makes your pain even seem worse. Other poor coping behaviors related to chronic pain. So people who have chronic pain often withdraw socially because they're not comfortable, and so they don't want to talk to their friends. They don't want to deal with others. And because of that, that also can lead to negative emotions, and we just talked about what that's going to do. Some people catastrophize their illness, so when they start feeling pain, they really start sort of making it seem like this is the worst thing possible, making it seem like it's worse than it actually is. And the problem with this is that, like I said before, this is going to lead to more negative emotion and more pain, but it can also lead to improper treatment seeking. So if you are constantly catastrophizing and thinking that, this pain indicates that you broke a bone, or this pain indicates that your tumor has spread, or indicates that, you've got some kind of disruption in your head, or, who knows, that can lead you to go to the doctor more often and not really be sensitive to true, more subtle changes in pain that might be important for a doctor to see. And instead, you're going to be going over and over again and, potentially not really getting the help you need, because at that point, there might not be an actual change in your pain that a doctor could objectively help you with, or, anything that your actual underlying cause of the disease is changing that might require treatment seeking. And it might even, who knows, if you go to the doctor too much, you might be less likely to go to the doctor when you need it because you feel like they're never really helping you with with your pain symptoms in the first place. Other coping that sometimes happens with pain is wishful thinking. So if you have chronic pain, you just want to wish it away and you just hope it will get better. And again, that's a very passive coping strategy, and so it's not necessarily going to lead to any kind of better outcome. Now, unfortunately, the one real hallmark of chronic pain is that it is resistant to treatment. And we mentioned that on the last slide when we were talking about benign pain being a specifically unresponsive treatment. But this is kind of a hallmark of chronic pain in general, is that it just is lasting over 6 months because treatment is not really helping it. On top of that, as we talked about with chronic disease in general, it does complicate your social relationships when you're in chronic pain. You can't enjoy socializing in the same way. You might not want to be touched. You might not be able to carry on sort of fun conversations because you're in pain and it is making you feel very negative. And in general, it can just completely disrupt your life. It's very hard to work at a desk all day if you have chronic back pain, for example. It's very hard to give a presentation if you've got chronic migraine. And so these things can very much interrupt your job. It can interrupt your ability to socialize, and in general, just make you very depressed because of all these sort of disruptive elements of the pain. Now, as far as how prevalent chronic pain is in the environment, about 15% of U.S. adults have chronic pain. So that's actually have chronic back pain. So that's a fair amount of adults. And over the course of their lives, most people do have back pain at some point. About 20 million U.S. adults have arthritic pain. About 40 million suffer from headaches, since that's a very large amount. And the pain industry is considered to be very costly at about $100 billion per year in the United States. Like I said, even though 15% of the U.S. adults suffer from chronic pain at any given point, 85% of the people in the U.S. will eventually suffer from back pain in the course of their lives. And so this is a very common problem. And when we look at nursing homes specifically with older adults living in care or assisted care facilities, 25% of them have chronic pain. And so as we get older, this does become more common, partially because a lot of the time this chronic pain is comorbid with other chronic illnesses. So if you have cancer, you might have some kind of pain that goes with it, for example. Now, like I said before, pain or chronic pain specifically can be an example of a chronic illness, but it's also a symptom of chronic illness. So when we talk about what makes you go to the doctor in the first place, people who have mild, weirder symptoms, maybe they see spots, or maybe they're a little bit dizzy, or maybe they just feel a little bit under the weather, that might not be something that is potent enough to make someone actually go and seek out treatment from a doctor. But the one symptom that does make people go to the doctor most often is symptoms of pain. And so because of that, doctors do see a lot of people with pain. Unfortunately, it is related to so many physical disorders that the pain is not something that doctors are really that interested in. I mean, they really see it as being related to psychology, that, it could be partially related to just being depressed or anxious. Like we talked about, there's this bidirectional relationship where when we're in pain, we feel more negative. When we're negative, we feel more pain. But again, the issue is that it's related to so many things that the doctor is really going to be trying to find the cause of the pain, and that's what they're going to be concerned about the most. But the patient is really most interested in getting rid of that pain symptom and just getting pain medication or something like that. And that creates a bit of a barrier in doctor-patient communication. And we're actually going to talk about that in week 10 and talk about how important it is that doctors and patients communicate well to properly have a good treatment outcome and adherence outcome where the patient actually follows what the doctor wants them to do. Okay, so I briefly mentioned this in class on Tuesday, but just to clarify what we were talking about, pain is very interesting as a symptom. When we talk about heart disease, you either have heart disease or you don't. When we talk about cancer, you either have, mutating cells or you don't. Pain, on the other hand, is something that is very context specific. And so it is the case where you might have pain in one situation and not in another. And that is different than almost all of the other illnesses that we've been talking about in this class, where you're either sick or you're not. And so I just wanted to go over some examples that kind of show this context sensitivity. So the place where I really always think about pain being so context sensitive is when you look at Olympic athletes and professional athletes, and you hear about these amazing times where they're able to push through some horrible injury like a broken rib or a concussion and still play and win a gold medal, for example. And so here's just an example of an Olympic skier who's had a torn knee ligament, concussions, lacerated liver, broken ribs, punctured lungs, and is still able to win World Cup titles in her career. And so clearly she is someone who is able to experience pain and keep pushing through and still successfully, complete her job and do it in a very powerful, successful way. And we can see this in non-Olympic athletes as well. So the example that I quickly brought up in class on Tuesday was, if you see a little infant or a child and they fall and scrape their knee and they're by themselves, they might just kind of pick themselves up and go on their merry way and keep playing. But if the child is close to their mother or father, then what you often see is that they run to their mother, they run to their father, they start crying, they're really upset, they're inconsolable. And so it's a completely different pain interpretation depending on who is present to watch it. And so you can see right then that even the same injury in two different contexts can be experienced in very different ways. A very famous example that you can read about in your textbook is that, during World War II, what you see is that there are these soldiers in the field who just amazingly, get shot. They have major lacerations and injuries, and almost none of them actually asked for morphine for the pain. About a quarter of them would. And, we don't really know why this is the case either. Adrenaline from being in the field, maybe it's a masculinity thing and they didn't want to, be seen as weak by taking morphine, but for whatever reason, they were able to tolerate the pain and not take anything for it, even when the wound was, by definition, something that should be hurting a lot. On the other hand, when we look at home, the same psychologists or doctors who were seeing soldiers at the war, and they go home to the United States, they would be seeing patients with very minor ailments who were absolutely demanding painkillers, and about 80% of civilians were demanding them in this example from the book. And so what this really shows us is that pain is something that is somewhat subjective. It doesn't mean that it's not important or meaningful or causing disruptions to quality of life. It just means that it is something that does depend on the person and the situation to some extent. As far as how we measure pain, it is a very highly subjective measure, but the way that we assess it is, what the person feels. And so we're not trying to put an objective number on it. We're really asking you on a scale of 0 to 10 or 0 to 100, how much pain are you in? And so here's just an example that we see a lot, which is using smiley faces and sad faces, or using some kind of varying, pain that can be ignored to pain that interferes with tasks kind of definition. But the most common one is the one on the top, which is this sort of verbal descriptive scale where you go from no pain to the worst pain possible. And again, the worst pain possible might vary from person to person, but when we're monitoring you and your pain, and maybe we're in a doctor's office trying to manage that pain, what does matter is how much pain you're in. And so even if it is relatively subjective, this is still very useful for us to see how your pain is changing. This is a very popular pain scale, one that is done by one of the world's sort of most known pain experts, and it's called the McGill Pain Questionnaire. It was developed at McGill University in Montreal, Canada, and instead of just asking on a scale of 0 to 100 how much pain you're in, what we look at is more specific sources and types of pain and causes of pain, and this might help a doctor or a researcher understand better where this pain is coming from, because different illnesses can be related to different kinds of pain. So for example, a pain that is throbbing versus a pain that is shooting might mean something different to a doctor, or a pain that's pinching or tugging might be different than a pain that's sort of more tingly or itchy. And so this really does help us better understand the pain. And then also we've got these nice pictures of the body, and people can circle where the pain is, which again will help a doctor figure out what's going on. And then on top of this, what you actually see here is some psychological descriptions of the effects of the pain. So pain that is, tiring or exhausting, maybe it's fear-inducing, maybe it's annoying or troublesome. And again, this will help a doctor or a researcher understand the consequences of this pain and how serious it is on a varying scale. And again, like I wanted to mention, pain is very, very much tied to emotions. The same way that neuroticism, like we mentioned a few slides ago, is tied to the experience of more pain. Negative emotions are absolutely tied to exacerbated pain, and when we're in pain, this makes us feel more negative emotions. Depressed people, for example, very much often feel a lot of pain, and so this is something where it's not too surprising to see negative emotions listed, like fear, on this scale, and exhaustion, just because these two things are so closely tied together. Now, as far as how we manage pain, we talked last class about how to manage chronic illness and how complicated it was, and how we often use a multifaceted approach. There might be a dietitian for chronic pain, there might be a physical therapist. With pain, we also often do take a multifaceted approach as well. Again, chronic pain is a chronic illness. But some of the techniques that we use are a little bit different, and there is often a lot of psychology and complementary and alternative medicine involved. Drug therapy is obviously a first line of defense. Surgery, if the pain is, caused by something that could be surgically altered. And again, this is what most doctors are trained to do. It really is, pharmacotherapy, for example, a very common first step. So giving someone some kind of medication or, that might help them with their pain. But we know now also, because of the sort of emotional piece, that we might be able to do some things with more psychological procedures. These might be relaxation, these might be hypnosis, mindfulness meditation has been very popular, acupuncture. A lot of these were things that Marie talked to you about when she gave her lecture on complementary medicine. And also, biofeedback has been something that psychologists have been using for a while. What that is taking some kind of signal in your body. So it might be your respiration rate, it might be the activity of a muscle, something that you wouldn't normally have access to. And we will show you or give you information on that signal by maybe playing a tone or showing you on a screen how active that muscle is. And then basically teaching you and teaching your body to turn that activity off, and that will somehow help you. So for example, if you have TMJ pain, which is that pain around your jaw that some people get where their jaw clicks when they open it, what is often causing that is tension in your jaw. And so what we could actually do is put electrodes on your face and actually monitor the electrical activity in your jaw muscles, make you aware of that by maybe showing you a picture of how active your muscles are, and then teach you to relax your jaw so that on your own you can practice that when you feel TMJ pain. And that kind of training over time has been shown to reduce pain to some extent, with some mixed evidence on how effective it is. Now, of course, with a pain in the moment, short-term pain, especially when you're talking about these sort of acute episodes of pain, even distraction can be very helpful. Just having someone think about something else, using other coping techniques like we talked about, maybe emotionally managing the coping, seeking social support to help you with it, maybe exercising. There's lots of different things you can do. And now what's been more common is to also have pain management programs that have a combination of many forms of these activities. And they might even bring the family in to help with the social relationship component, have the family help provide support and deal with the pain as well. So here's just a picture of biofeedback. So this is a person who probably has headaches because she's got these electrodes on her brain, and so that's probably doing some EEG biofeedback. It also looks like she has an ear heart rate sensor, so you can actually monitor heart rate in the ear. And so what people could do with this is by looking at EEG brainwaves in your heart rate, is you could teach the person some relaxation exercises that would lower their heart rate and alter their brainwaves in a more relaxing way. And this is really just teaching them these relaxation techniques that might actually help them with the kind of pain that they have. And relaxation in general, because pain is such an arousing situation, just letting the person relax is often very effective at teaching them to manage the pain when it happens. So when you feel that arousing pain and that negative emotion, to do those deep breaths, to activate your brain in this way that will help relax. And so it does seem to be something fairly helpful. But again, there is mixed evidence on when it's useful. Now, something else that we've done is just sort of general relaxation techniques. And so I've got an example on YouTube that I'll just click and show you, and we'll see if this works. And this is something that you can definitely do on your own. There are a ton of these kinds of guided imagery exercises, mindfulness exercises. Like I said, I think Marie did one of these with you in class where she had you go through a guided meditation. And so guided imagery is very similar.
Guided imagery and visualization for pain reduction. All right, now, I'd like for you to take a moment and just allow yourself to find a comfortable place, either sitting or lying down, and just sink in and imagine what it might be like to be completely and comfortably relaxed. And as you're using that imagination, you can allow your eyes to gently close and begin paying attention to your breathing. and your breaths. Just breathing in peace and calm.
Okay, so you get the idea of what's going on there. So, with these kinds of relaxation exercises, they will specifically have you often think about the pain and try to let it go, to try to not allow it to upset you, to sort of get rid of the emotional component of the pain. And so those kinds of videos can be very helpful because not only are they relaxing you and reducing your heart rate, sort of reducing the arousal tied to the pain, but they're also potentially teaching you some coping skills that will help you maybe reappraise the pain. So we talked about stress reappraisal when we talked about stress, and it will give you some strategies to reappraise the pain so maybe it's not as threatening of a stimulus. Now, this is something very important that I wanted to make sure we talked about because I think it is one of the cooler areas of psychology that is definitely very relevant when we talk about pain. So we've briefly talked about placebos before, but let's bring them up again here because placebos do seem to be something that is specifically helpful for pain conditions. And so what a placebo is basically any medical procedure or technique that produces some kind of effect because of its therapeutic intent, but not because of its specific nature. And so the hallmark placebo is something like giving you a pill that just has sugar in it as opposed to an active medication, and then seeing that sugar pill might be equally beneficial to whatever it is that you're looking at. And I've attached an article here from the New York Times that really talks about how amazing and powerful a series of studies on placebos have been recently, and how we're really seeing that there seems to be no limit on what placebos can do. Now, one of my favorite examples of a really powerful placebo is when they actually do placebo surgery. And so we're not just giving someone a pill that has nothing in it. What we're actually doing in this situation is faking surgery and then seeing that the fake surgery is associated with just as much pain benefits as real surgery. So in these kinds of studies, and I've got two citations below that you can actually look at the bottom of the page here, the Mosley study and the Blakesley study. What they did is they had people who are coming in for arthroscopic knee surgery, and this is the kind of surgery which I'm showing on the left here, where they're not cutting you open by any means. They're just putting very small instruments and using a video camera to do minor alterations to your knee. It might be flushing out, some dead tissue, or maybe sewing up a tear, something like that is usually what's done. And in this case with osteoarthritis surgery, it's a fairly minor surgery that is, like I said, kind of cleaning up some tissue and getting rid of any dead tissue and things like that. And it's been shown to be helpful for osteoarthritis. And so what they did in this example by Mosley is they had three different conditions. One was the debridement condition where they did the full surgery. One was a lavage where they did sort of half of what they would normally do for the surgery. And one was a placebo where they literally just kind of drilled the holes and put the camera in, but then didn't do anything, just took them out. And what you're seeing here is that before the procedure started, people had a pretty similar walking bending score. This is sort of a function of how much does it hurt to walk and bend, how much pain are you in. And at the beginning, all of them with osteoarthritis in their knee are in a lot of pain. But what you're seeing is immediately after, 2 weeks later, the placebo group is actually doing the best as compared to the two groups that had surgery. They're actually reporting less pain than the groups that had actual surgery and repair done to their knee. And as you can see from the error bars, there isn't really a significant effect there. Basically, what you're seeing is that, all three groups are almost identical. But what this is saying is that overall, in general, when you're getting osteoarthritis on your surgery on your knee, that the placebo is working just as effectively as these other techniques, if not better. It's not significantly better, but it's working a little bit better. And so there really was no difference there. And it's not just knee surgery that's been done. They've done this with depression, for example, and they've actually shown that people who have who take placebo antidepressants and it works for them, if you do neuroimage analysis on their brains, you can actually see that the different areas of their brain light up in the same way that the group who had the active medication. And so there really does seem to be some power, and pain especially, of believing that you just got a treatment that's supposed to help you. That, there really is something about this belief in the procedure that seems to be helping people with pain. And as far as how this works, it's not just something that's sort of in your head, people are making this up. It really is associated with physiological responses. And so what we see is that, if you imagine that something is reducing your stress, if you imagine something is reducing, if you imagine that something is working, so if you imagine that the surgery that you just had is effective, it will in fact reduce your negative affect and stress. And the result is that this can actually impact your physiology. So if you do something that makes you feel less stressed, we know that that reduction in stress is going to improve your immune function, is going to also improve your heart rate, because we've seen that with the stress studies. And like I said, it's not just in your head. You actually do see changes in the brain when these placebos work. And so this is having some kind of physiological effect that is in fact real. Now, the interesting thing about placebos, and people have been doing a lot of studies manipulating this, is that there are certain things that make us believe in placebos more. So, for example, if you have confidence in your doctor, and your doctor is telling you that he strongly or she strongly believes that this medication will work for you, then you are more likely to have that placebo be effective for you. If you're in a medical environment, there's people around you in white coats, and it looks very professional, and there's fancy medical equipment, and someone gives you a placebo. So, for example, the sham surgery kind of example where you're really in a hospital, that placebo will be more effective for you. So the more real that the procedure seems, the more real the medicine. And they've actually even shown that placebos that cost more are more effective. So that if you spend more money on a placebo, you'll believe it more, and that will seem to be more effective. So there are some psychological subtleties here, but this really does suggest that, believing in something can be an effective thing, especially for these kinds of subjective outcomes like pain and depression, where, some of it is more subjective. Now, what I want you to recall is how this might fit in with the perceived control literature that we read about. So we read a lot about, or we've talked a lot about, how believing that you have control over something can be very effective. So, for example, we talked about the old age home where people who had the plant to water got to pick, what time they ate, those kinds of things. Even though they weren't really controlling much about the nursing home, believing they had some control, even minor control, had them living longer, being less depressed, feeling better. And we talked about this example with the immune literature, where people who believed that they could control a tone, a really loud noise, were actually doing better immune-wise if they believed they could control it, even when they couldn't. And so I feel like this placebo effect really fits in nicely with the perceived control literature. You're basically giving yourself perceived control over your illness. You have this mindset that you believe that this thing works, and that belief, that perception of control, is somehow having a benefit for your health, and in this case, what we're talking about today, your pain, and it really can work very well. And so this is, I think, very good news, because, if we believe that something will work, it probably will. And so there really is nothing better than a good placebo. And so I think that this is definitely something to consider in your lives, where if you are having pain and you have some kind of, superstition of something that you think will help you, or you feel really stressed and you have some kind of lucky charm that will make you less stressed, that kind of belief will probably have a real effect on your health and on your well-being. Okay, so we'll leave it there, and hopefully this Camtasia thing worked out okay for you, and we'll see you in class. Have a good night, or a good day.